Thanks so much for inviting me here. I've learned a lot already. It's been a great meeting till now. Oh, so we don't get to pick our clickers today. You just have to do what the doctor tells you to do. That's interesting. I do consult for GSK and Merck, although I'm not going to talk about that stuff today. But my interest in predicting individual risk began roughly on March 4th, 1990, approximately 9:38 a.m. Central Time, when my doctor told me I had Hodgkin's disease stage 4. And I asked the simple question, Doc, what are my chances? Looking for a number. Doc says, this is the way we do it. This is the way we've always done it. We use the AJCC staging system. Everybody uses that. You just look it up. You go look at that, and I'm on this 4 curve, and I start to look at how does one get on a particular curve. And at the time, I'm a PhD student in the business school studying financial risk prediction, looking at this system, and it clicks to me that clearly there's no money on the table with this prediction system. Because if this is how you ran your financial business in a method of predicting like this, you'd be done in 5 minutes after the close of the bell, or the ringing of the bell. The key is, in the financial world, accuracy is job number 1. Predictive accuracy in the modeling, that's job number 1, and there is no job 2. Over here, accuracy, I'm not sure if it's even 5th, but there's ease of use issues, there's routines, the way we've always done it, and I think there's great potential for us to refine predictions and make more accurate predictions at the bedside, and lots of good things will happen if we do that. I didn't like this system because I didn't think it was designed for accurate prediction. When I looked at this, it didn't feel properly tailored to me. I was on this curve with stage 4, and there were other people in the waiting room next to me who were also 4s, who were 95 versus 22 or whatever I was, had many more comorbidities apparently than I did, but we're all in the same curve. We're all getting counseled the same. The extended disease issue I thought was too broad. When I pushed on my doctor, he said, well, you're not really a 4. I'm treating you as a 4. Technically you're a 4, but you're really a bad 2. There's no curve for bad 2. Do I hover above the 3? The system is pretty goofy. If accuracy is the goal, I don't think it is. It should be, though. But if you think about it, putting yourself in the doctor's shoes, and you say, Doc, what are my chances? What's Doc going to do? I think Doc is going to do one of these things. Either on the left, just size you up and say, yeah, Mike, you've got this going on, that going on, your chances are X. Or go down the evidence-based pathway of sorts to the right. Maybe give the overall average to all his patients. So you have Hodgkin's disease, your chances are X. Or put me in a risk group or a stage or something like that. Or what I want him or her to do is apply a model and out-predict, I would argue, anything else on this page. I would like him to take everything he knows about me and plug me into a model. So if I had clinically localized prostate cancer and I wondered what surgery might do for me, I'd like to take my PSA, see how important that is, and if I have a PSA of 10, give myself 55 points for that. What's my clinical stage? I'm a T2A, I'll get 10 points for that. What did the biopsy show? It's 3 plus 3, I'll give myself 23 points for that. Add them all up, whatever that was, I didn't count that. Let's say it was 100. I have 100 total points, draw a line straight down. Mike, if I had 100 patients just like you, I would expect 75 of them to be free of prostate cancer recurrence 5 years later. I just ran myself through a Cox model with a piece of paper. I'm a big fan of regression approaches in terms of accuracy in my hands. And the implication of that is on this page. You might get counseled by an equation like that. You're probably going to get tossed into a risk group if you have prostate cancer, and it's probably going to be this one, the D'Amico grouping that's in pervasive use, but it's got 3 buckets, lower, intermediate, and high. Here I'm going to take the same, these other guys are taking the same patients, and they're going to put them in the bucket, and they're going to plug them in the nomogram I just showed you and compare the predictions. An X is a patient. Head-to-head, the predictive accuracy, well, I should say discrimination by concordance index, substantially higher by this approach than that approach, but this is the implication. This guy, I'll give you that, he's high risk. He's in the high-risk bucket. His chance of making it 5 years without recurrence are about 1%, high risk. This guy I wouldn't say is high risk. He's got about, by a more accurate prediction system, a 95% chance of making it 5 years without recurrence. I don't think he's high risk at all. He's going to get overtreated. Those guys are going to get undertreated, and it's the problem with the risk grouping approach as I see it. You get too much heterogeneity in there, and we need to get that out. Here's an individual. In our setup, he has a reasonably low PSA. Other things about this guy are not that good, and he's trying to get some opinions. He doesn't know what to do about his prostate cancer. Let's go to the urologist. Nope, going to the radiation oncologist. Well, you're in the favorable risk group, so your chances of making it without recurrence are 81% at 5 years. When do you want your radiation? Well, I want to get a second opinion. I'm going to go to the urologist. Go to the urologist. The urologist plugs him in the nomogram I just showed you. 68% chance you'll make it 5 years without recurrence. No thanks, I'm going to get radiation. Why is that? Well, I just saw him. I'm in the favorable risk group, 81% chance of making it 5 years. Risk group, let's plug you into a radiation therapy regression model and see, because head-to-head on neutral data, it outpredicted it. Let's see what that number is. It's actually 24, not 81. How many patients get to that level of refined prediction? The business model fights this. There's no one's willing to pay for that kind of thing, but that's a pretty dramatic swing, I would think, for this poor guy. Heterogeneity here, and looking at, if you have gastric cancer, you say, doc, what are my chances? Post-operatively, doc's probably going to use the AJCC staging system. A regression model, head-to-head, has better discrimination, and you can see heterogeneity. Look at the stage 2s. You might be this guy who's got a good, reasonable prognosis. You might be that guy. Do you need treatment beyond surgery? If you're using a staging approach, you got a decent shot of being kind of mislabeled there. So in my experience, a continuous sort of model, a regression equation versus a risk grouping system either gives you a little bit or a lot of improvement in discrimination. Those are prostate cancer examples. Those are non-prostate cancer examples, but the issue's the same. I tend to get better results myself with a regression equation approach versus trying to find the similar patients. I think you pay too big of a price on your sample size and other issues with that. But at the end of the day, I'm agnostic. Whatever predicts as accurately as you can get is good in my book. But we're still going to have resistance because the models are all wrong, as we all know. And you can look at any of them and have concerns, complaints. It doesn't contain this predictor. The relationship can't be like that. The data set's lousy. It's coming from an EHR, on and on and on. I'm not going to use your model. I'm going to fall back on my own clinician judgment. Let's hand out 10 vignettes to 17 urologists and put everything we know about an individual patient on a sheet of paper. Hand it out. Plug the patient into the nomogram I showed you and get the prediction that way. Ask the urologist, look at the extra information, look at what the nomogram is predicting. What do you think? Is it too high, too low? Take into account the extra pieces of information, because there's a lot on this page and the nomogram's only using 3, and tell me what you think. The urologist did that. They deviated from the nomogram. Area under the RC curve, concordance index fell when they took the extra information into account. They should have just stuck with the lousy prediction that they didn't like in the first place. Let's go to breast cancer. Should a woman who is sentinel node positive get full axillary lymph node dissection? Another good controversy. Well, if you do that, here's the probability that you'll find cancer. I'm not going to tell you what to do, but I'll calculate the risk for you. You want to use this tool? No. We see thousands of these women a year. We know how to calculate this risk. Really? Let's go head-to-head on a set of patients that I didn't use in the modeling and look at how you do. Clinicians as a whole, about 0.54. The tools, about 0.72, where I said it was before, and you didn't like that. That wasn't good enough. Individual docs over here, 6 at or below a coin toss at this task. It's not easy to do. Final nail in this coffin. Let's go to a medical oncology ad board and talk about advanced prostate cancer. Who needs to be treated aggressively versus watched with a rising PSA? Who's going to develop METs within a year if you do nothing? Would you like a tool that predicted that? Answer, no. We have a gestalt. And I don't know what that is. I clearly don't have one, but they all do. And what's curious to me is how different everyone's gestalt is. Here's one of the patients I handed out to the group. These are the doc's predictions for that same patient. They're jittered. So this doc says this guy has a 5% chance of developing METs within a year if I don't treat him. That same patient, by that doc, it's a lock. So this gestalt thing, I think, is overrated myself, because they're all different, and I'm comparing what the gestalt is in this to the red. If you follow that across, a letter is the same doc followed all the way across. Overkill on this slide. The colored thing is what the prediction model, the Cox model that I didn't even make in this race, what the regression model is predicting for that same patient. It's actually the wrong model for the outcome as I've defined it, but it's the closest one in the literature I could find. It's defining the outcome differently though, but that's the best I could do. The circled patients are ones who actually did develop METs. So ideally you'd say, 100 for those guys and 0 for the rest. This time all docs lost to the tool, but only one was worse than a coin toss. So I guess that's refreshing. And it's not a doctor bashing, it's not a doctor problem, it's a human being problem. We're just not built to compute probabilities in our heads, I would argue. Most of us aren't. Maybe some people in this room are, but as a general rule, we've got too many biases involved to get that done properly. So where I want this to go is, as I see comparative effectiveness as a table like this, by and large, it's what are my treatment options or strategies or possibilities, including nothing, and how do they compare with respect to benefits and harms? And I want this tailored to me, though. That's the hard part. We do this all the time on Amazon.com, looking at cameras, but don't have to tailor it. We can look at the same result. Here it's got to be tailored. That's a lot more work. But if we had this, I think lots of efficiencies and better decision making would take place if we could get that type of information handed to us. It's not easy to do, but here let's do it with diabetes, since that's the theme of the day, type 2 diabetes. Let's go to Epic, our electronic health record. Click File, Export. Give me all your type 2 diabetics from the time they started an oral diabetic medication, and let's follow them for some good and bad things, and give me the characteristics at baseline that the docs think should be important predictors. Those include age, gender, and you can read the rest. Get that out, model all these things, wrap it up in a single interface to run all the models at once. So I'm going to take this guy right here, fill him out, hit the submit button, run a bunch of models at once, pull it back like that. Well, Joe, you have 4 major drug classes available to you today. Here are your 6-year predictions as best we have it from Epic as to whether, for example, you're going to die. On the biguanides, it's about 1%. In second drug class, jumps to 12. Let's color code it. The green is the best in the row. The red is the worst in the row. That way, if you believed in this and these were the only outcomes you cared about and a few other handy assumptions, if you saw a column solid green, you'd have a no-brainer with no trade-offs involved. I try to make these grids. I stop 9 days out of 10. I stop short of layering preferences on top of that and then saying do this. I think I like that approach, but that's ultra hard work. But I think if we can give these kinds of grids to folks, if you have a Vioxx or something, it's going to die a natural death. You don't need to black box it or take it off the market. It's going to be inferior on this stuff, and you're just not going to pick it. Why would you want that if it's truly that? Or if it does have some benefit that you really care about, and it's a reasonably rational choice to opt in for that, then great. But now at least you're informed and you know what you're getting into here, I think, is what we need to do more of. We've got a whole bunch of these calculators up on our website that's listed here. Probably more interesting, though, than that for this group is the little button there says Make Your Own. Through stimulus funding, you can click that button, and that takes you into an interface. So if you're the statistician and you have a model that you like, but you're not a web programmer and you don't want to pay for that, this is free. Go to your stat software, copy, paste in your equation, fill out some housekeeping stuff of what you want the min, the max to be. There's no programming here. It's just copy and paste and then making some choices about naming conventions. And boom, you've got your own web risk calculator. Brand it yourself, use your own logos, call it whatever you want. That's all under your control. It's cropped here, but there's a link that you click on to get the publication if you want to list that, which I think you probably should. But as a way of at least removing this barrier, the dissemination barrier, that seems to work pretty well. We do integrate with Epic, in fact. So here I'm taking care of the patient within Epic, and I've got his PSAs and his dates. I click that button that says launch the risk calculator. That takes me to this screen. It brings with it whatever I need coming from Epic, pops it in over here. I can revise these numbers if I see an error, add more numbers if I actually know them, that they're not in Epic, do whatever I need to do there, refresh that calculation, but run whatever equations I want to run. In this case, the PSA doubling time is of interest to me. But finally, I know electronic health records have gotten a bad reputation over the past couple of days, but it's not that bad. It's not purely monkeys and keyboards, because I think if it were, I couldn't predict anything. If it were just random noise, I'd probably get a concordance index of about 0.5 on that, and I'm reasonably higher than that, so I have faith in that. Not perfect, lots of issues going on here that we can run from, but if you get too paranoid, what do? You run back home, get under the covers, and hide, and just do what the doctor tells you to do, and that's no good either, I don't think. I think we got to get models out there, and hopefully the model we come up with tomorrow is better than the one we've got running today, and just trying to march that forward with improved predictive accuracy, whether that's new biomarkers, cleaner data, whatnot. But I think the key framework here is predictive accuracy, and that's how we need to compare what we're doing. Because we've got lots of arguments for, should I model it this way, should I model it that way, should I use this data, that data, these predictors? What are you trying to do? Doc doesn't really need p-values for this. It does need confidence intervals. That's going to be controversial. Any of this kind of stuff, he needs accurate predictions. And so we need to judge our models on their ability to deliver that. But I think if there's a trade-off involved, we need to be giving patients those kinds of predictions. And I think regression models are the way to go on that myself. But again, whatever works better. But I have better luck with that than I do with clinician judgment, risk grouping, counting risk factors, those sorts of things. The web software is free as long as we can keep it funded. And the biggest challenge, as I see it, is follow-up data collection. That's the hardest part, I think. I know it's not very sexy, but no one wants to pay for that. It's just blocking and tackling, and we need to, at our place in particular, follow patients who don't come back because they've been treated, and they've been cured, of course, with no complications, so we don't see them again. We'd like to know that just to be sure, and that's expensive. I better stop now. Thank you so much.
So in a heroic act of transportation accomplishments, Peter Bach, who we were told was a victim of the sequester, stuck on the runway in New York City, has actually made it here, which is terrific. But Peter, we'll give you an opportunity to settle in and have Mitch Gale start off as a respondent and then have you follow. So we'll ask Dr. Gale, who's senior investigator in the biostatistics branch at the NCI and has been a contributor for yesterday and today, to join us.